Hybrid Thulium Laser Incision and Bladder Neck Contracture, Surgical Technique and Early Outcomes. Nothing to declare. Objectives. Bladder neck contracture is a common complication of surgery for benign prostate hyperplasia. Endourologic therapy should be the initial therapy for bladder neck contracture. However, best endourologic treatment modality yet has to be defined. Hybrid thulium laser has lately been introduced in urology with promising results in prostate and urinary stone surgery. Objective of our study was to investigate feasibility and results of hybrid thulium laser bladder neck incision. We included patients with a symptomatic bladder neck contracture, and we excluded patients with a vesical urethral anastomosis stenosis after radical prostatectomy. Moreover, we excluded irradiated patients. Perioperative outcome was recorded, and follow-up was obtained by telephone interview. We included 10 patients with a mean age of 76 years. Initial BPH surgery was TURP in 40, thulium laser enucleation of the prostate in 50, and bipolar enucleation of the prostate in 10% of the patients. Amount of resected tissue was median 32.5 gram, and time from prior benign prostate hyperplasia surgery was median 20.5 months. 4 patients presented with an indwelling catheter prior to surgery. In those patients without a catheter, maximum flow rate prior to surgery was median 5.8 milliliters per second. Moreover, patients had a median residual volume of 250 milliliters. Here you can see the video of hybrid thulium laser incision. Laser setting of the incision is always with an energy of 1 joule, a frequency of 60 Hz, and a power output of 60 watt. Initially, a cystoscopy is performed and urethral orifices are identified. Second, the external sphincter and the vermitenum are identified. In this patient, an indwelling catheter had to be removed prior to surgery. The incisions are made at the 5 and 7 o'clock position, as initially described by Turner-Warwick. The incision comes from the bladder neck and goes to the paracollicular space. Goal is to reach the prostate capsule. Particular attention is paid to retain a strip of mucosa between the 2 incisions. The strip of mucosa builds the basis of re-epithelialization of the healing wounds and prevents scar tissue formation again. The prostate capsule can easily be identified here. The second incision is performed analog due to the first one. Depth of incision is down to the prostate capsule, and length of the incision is from the bladder neck to the paracollicular space. Again, the strip of mucosa between the two incisions is of utmost importance. So, a proper re-epithelialization of the wounds can be guaranteed. Finally, after the surgery, urethral orifices and external sphincter are checked. The bladder neck now is wide open. A 20 French Foley catheter is placed. This catheter is routinely removed 2 days after surgery. Time of surgery is median 8 minutes and 50 seconds. Total laser energy is median 4.8 kilojoule. And median laser on time is 1 minute and 25 seconds. Here you can see that the maximum flow rate at time of catheter removal is median 38.7 milliliter per second. Median residual volume is 24 milliliters. No patient claimed to be incontinent at time of catheter removal. With a median follow-up of 12 months, we see 1 patient with a bladder neck contracture recurrence. No patient claimed to be incontinent at time of follow-up. We conclude that treatment of bladder neck contracture by hybrid thulium laser incision yields promising results. Complications are neglectable, and investigation in a larger cohort with a longer follow-up is needed.